And so all right, so if everyone is comfortable with it, just the got it button and then we can proceed. So next slide, please. And with that, I'll hand it over to Excel.
Excel, you're muted.
They say that's the most repeated phrase of 2020 and 2021, and we're still not getting it right. Anyhow, thanks so much, Grace and Megan and everybody else who had everything to do with organizing this event. I'm thrilled to be here, thrilled to see so many participants and some familiar faces. This event, I'm Excel Janser, I'm the Executive Director of Access Alliance Multicultural Health and Community Services. But when we talk about interpretation, I like to say that I was involved in the development of community interpretation initiatives and efforts before I came to Access Alliance. And in fact, that was one of the things that attracted me about this organization, that it had an interpretation program and was very committed to this matter. I, in fact, was one of the first community-based trainers of interpreters in Toronto, well over 25 years ago. So just, you know, those are my credentials in this area. This event today is part of Community Health and Wellness Week, which is organized by the Provincial Association for Community Health Centers, Aboriginal Community Health Centers, community family health teams, nurse practitioner-led clinics, and it's organized. So the Alliance for Healthier Communities has organized Community Health and Wellness Week, and this is one of 3 webinars that Access Alliance has organized this week, and they are all focused on areas of research or investigation that we are engaged in related to important issues that we're working on. So on, you'll see on Monday, we presented on tackling stigma related to TB in particular. Today, real steps to language access. And then on Friday, we have confronting housing discrimination against LGBTQ plus newcomers, which is linked to a research we did beyond positive intention. So we're really excited to be doing this work. I just want to start by saying that in Canada, the development of community interpreting and access to interpretation services are located within our immigrant history and culture, the development, very linked to the development of immigrant services and the commitment on the part of immigrant service organizations to equity, inclusion, quality of care for newcomers, and access to services. Access Alliance's origins are grounded in being very aware of barriers faced by non-English speaking newcomers to Canada and the need for systemic change. I mean, we can provide lots of services on the ground, but if we don't change those systems supported and created barriers, services on the ground will only achieve so much. So as a result of this grounding in understanding and being committed to the need for systemic change, we have been very engaged in the movement for strengthening, as have many partners, in the movement of strengthening and professionalizing community interpretation. So, you know, this is from the on the ground practice perspective, where we've worked in so many different ways, creating access within health and human services to interpretation, from the policy development place, where we've, you know, in the absence of any policy, because absence of policy is as problematic policy, where we've been working for, advocating for policy speaking to access to interpretation, services in health and community services, advocating for policies related to minimum standards, you know, not only in health and human services, but in the court systems and immigration systems, and then subsequently funding for interpretation, because before you get funding, you need policy, and, you know, we advocated for policy to drive funding. We also have been engaged in identifying competencies. You know, interpretation is a skilled profession. What are the competencies required? And then developing competency-based training programs initially these were community-based, but now they are located in our colleges, which, is a huge achievement and, a system commitment. And then contributing to research so that we can better understand the impact of language, access to language services, and impact of language on quality of care, patient and provider experiences, and cost of services. So this has been a long, many years process focused on systemic change, as I said. In my career, because I've always worked in immigrant service organizations, I've talked about how hard it is to actually achieve systemic change. And definitely our experience at Access Alliance in this space in relation to community interpretation is one of our success stories. And I've always said, I can count on two hands times that I've been involved in systemic change, and I have been working in the sector for over 40 years. So the energizing and amazing thing about achieving systemic change is that it's all about collaboration, creativity, and partnerships. We all work together to achieve this change. No one owns it. We all own it as committed individuals and organizations. And I've barely touched on the surface. This is it's a big umbrella, and there's a lot of moving parts, and a lot of change has been achieved. All of you, have been part of this process. In terms of our panelists and other partners, everybody who, contributed to all of these industry publications. So I super thank you for that. We have a lot of work still to do. So, we can't rest on our laurels or be complacent, but thank you. So over to you, Grace.
Okay, thanks, Excel. So we're just going to kick off on telling you a little bit more about the report. And so when we set out to write this report, we had a few goals in mind. And one was to provide an update on the research that's happened over the past 10 or so years since writing the 2009 Lit Review. That one was called The Costs of Not Providing Interpreting in Healthcare. And then to go beyond the idea of what happens when you don't do something to what are the benefits and the value adds when you do something. So when you invest in language access, what are the value adds? What are the benefits? What are our return on investment? And then we also wanted to highlight the Canadian research that's been new in the last 10 years. And then we also really wanted to make this not just an academic piece, but to make it relevant and accessible to health service providers, to policy influencers, so that they can take away some pieces and to help build their business case for promoting language access initiatives. So next slide, please. And so one of the ways that we made it relevant was by framing the research so it would align with the quadruple aim. And so by doing that, we really think that it advances the argument that language access initiatives really lead to a better, higher performing healthcare system by focusing on and aligning the research findings with better health outcomes, lower cost of care, improved staff and provider experience, and also improved patient experience. So next slide, please. And, again, to make it accessible, instead of just being, pretty sure that not everyone's going to have time to read the full 16-page report. So if you only have time for a couple of pieces, there is a one-page executive summary, again, outlining the alignment with the quadruple aim, some sound bites to walk away with, and then the 4 calls to action, as well as just sort of a table summary of the research. So pieces that people can just copy and paste into any slide decks, presentations, or elevator speeches that they're looking at making to support, again, language access. And next slide, please. So, and what we're here to talk about today, because another thing that makes it relevant is getting us all in a space like this to talk about what we're doing to actually move language access in our spaces. So we named 4 calls to action: mandate education for all health system employees, so top down, from leadership governance to frontline, on the risks of not providing it, and then also the benefits for investing in it. Then also number 2, the second call to action is integrate language access into your standards of practice and policies across the board at institutions in healthcare across Canada. And also build it into your performance measures and indicators. So any dashboards that you've got, we want this to be a piece of it. And then number 3, establish core government funding for all healthcare institutions, just to make sure that it is not just something that is funded when there's a surplus, but to make it a standard centralized funded budget line across the board. And number 4, call on research institutions to develop reliable ways to quantify costs and benefits associated with investing in language support. So this is still an area that is a lot of development, but we think that this would, more that is put into really structured and well done research, the easier it'll be for us to prove our business case. And so I think, right, so if you haven't seen the report yet, a couple of places you can find it. Of course, if you've got a mobile device, you can scan the QR code here. Otherwise, at our website, aalanguages.ca, just go to the events and language access initiatives. We've also made it available in RioMix, which is our multilingual health information online repository. So in addition to all of the multilingual health information that's there, we also have some pieces like this that are intended for policymakers and health service providers about working in language access. So go to riomix.ca, enter as guest, and then just start typing the keyword search of Lit Review, and it'll take you there. Okay, so I will now hand it over to Megan, who has helped coordinate and pull this whole event together to introduce our panelists.
Thanks, Grace. So on our panel today in alphabetical order, that's how we determine the order, we have 5 panelists with us from around the world, across Canada and even internationally. The first panelist is MPP Dolly Begum. She's the member of Provincial Parliament for Scarborough Southwest and is the critic for citizenship, foreign credentials, and immigration services. MPP Begum's work on language access includes supporting legislation aimed at national recognition for Mother Language Day and focuses on making government services more accessible and equitable by removing language barriers. Next is Lola Bandana. She's the director at Multi-Languages Corporation, member and past president of the Canadian Language Industry Association of Canada, and a member of the board of directors and past president of the Ontario Council on Community Interpreting. She's also an expert delegate member of the Canadian Advisory Committee to the International Standardization Organization, a working group responsible for the development of international standards for translation and interpreting processes. Thirdly, we have Nishi Kumar, who is a program evaluator and policy analyst focused on health equity and the social determinants of health. She holds a Master's of Public Health from the University of Toronto and previously worked with the Wellesley Institute as a junior fellow. She currently lives in the Boston area where she works as a research consultant for public sector clients, leading research related to housing, community development, and economic well-being. Next is Dr. Aitor Montes Lazarte. He is a family doctor and professor, as well as an ardent language access advocate located in Basque Country, an autonomous community in northern Spain with its own distinct language. Aitor studied medicine at the University of the Basque Country in Europe and carries out family medicine at Galdacao Hospital. Lastly is Angela Sasso, and she's the founder and director of the Interpreters Lab, a program of shifting pictures, and president of Critical Link International. Since she began working as an interpreter in 1989, she has held positions as a senior level manager, interpreter educator, researcher, program manager, policy developer, and expert consultant with various organizations in the area of language services and equitable access. And Angela's joining us today from Vancouver, British Columbia. So if we move to our first call to action that Grace already went over, we're going to start back here. And we're going to have start with the discussion here. So we're going to pass this to Grace. Fill me in on who's starting this discussion.
So I think that we were hoping to call on Aitor to lead the response for our first call to action, talking about mandating education for all individuals of the healthcare system, from governance to the front line. So if we can hand it over to Aitor to start us off, that would be great.
Can you hear me? Oh, really?
There's some feedback, but we do hear you.
I hear myself really bad.
Oh, we see you logged in twice. That might be why.
Yes, that's true. No, está. Can you hear me now? Better.
Perfect.
Okay. Can I start? Okay. Well, first of all, I agree absolutely with the report. I mean that education at all level is needed, is required for two reasons. There's a huge evidence and compelling evidence on the benefits and outcomes of language access and interpreter services, and demography is changing all across the world with increasing language diversity in every country. Okay, you have highlighted the need to perhaps more research focused on the costs and benefits and risk, perhaps addressed to managers and stakeholders. I agree with that. Perhaps I will add that we need more research as well in bilingual countries like the Basque Country or Sweden or Wales or even Canada with official languages. I will add as well that probably we need more handbooks or textbooks in order to implement education in this field and address and therefore adapt to different professionals. I mean, nursery and medical students, but health providers, managers, stakeholders. So this is a question or inquiry to all the panelists and participants. Do you have enough textbooks, handbooks, or adapted to your necessities? Okay, secondly, the report is aligned with the quadruple aim, which is based on the triple aim of Berwick and colleagues. 13 years ago, they pointed out that literally the remaining barriers to integrated care are not technical, they are political. And I agree absolutely with them. They highlighted that they need a kind of integrator or coordinator, an entity, an organization that will accept the responsibility to achieve the four goals and to establish partnership with patients, with families, and with other entities. In our country, this is quite easy because it's a small country of only 2,200,000 people with our own self-government and our own NHS, National Health Service, a public health service which offers public and universal healthcare, free and the point of delivery, and financed only by taxes. So it's clear we have one organization, the Osakidetza, the Basque Health Service, Public Health Service, which could be our integrator, our coordinator. So here my second question, my second inquiry to the panelists. Which entity or institution do you consider that could be the most appropriate integrator or coordinator to implement in the implementation process of language and interpreter services in the field of healthcare, and particularly if we want to achieve mandate education, which institution and how to convince this institution, how to press it, maybe the federal government, maybe each province or territorial government. Well, another question, sorry. Health professionals education is not only in the working place, it starts at the university. So I think that we should need to embed this subject, the subject of health and language, of course, interpreter services, how to work with them, what are the interpreter services from the start. Nursery schools, medicine schools as specific subject, and at the same time, perhaps consider as a transversal issue in other mandatory subjects, and medicine and nursery schools. After this, what we have proposed and we are trying to achieve in the Basque Country are post-grade education, online courses, massive online open courses, summer university courses, and post-grade degrees, masters, or doctorate programs. For example, in the Basque Country, we have carried out 4 editions of our summer courses focus on this issue with Canadians and Welsh and Basque experts and health professionals. And we have carried out 2 editions of our postgrad course, which offers to the attendants an expert title. I mean, you can obtain an university, an official title of expert. It is entitled Management of Language and Clinical Communications. However, I think that this is not enough because it is perhaps too academic and not perhaps as relevant as we should need. So the next step is it should be to embed this in the ongoing training of every health professionals. I mean, it doesn't matter what is your professional category, nurses, doctors, managers, or stakeholders. But unfortunately, we have not yet achieved this second or third stage in our country. We're trying to do this, but we have not achieved. We are only limited to the academic field. I mean, postgrades, summer courses, and the like. I can guess that this is perhaps the lack of an institutional commitment, that the Basque government and the Basque National Health Service are not truly committed in this process of implementation. And therefore, we have relied only on the thought and commitments and volunteerism of health professional and professor. And I think that this is a mistake and that's not enough. And I recommend you to take this into account, not rely on professionals or personal effort, but trying to enforce the institutions to embed this in the ongoing training and not limiting it to the academic field. Okay, so that's my conclusion in this aspect. We need a strong implementation of the Basque government and the Basque Public Health Service and to establish a partnership with other entities to create a real serious educational program in order to change the awareness of our health professionals, their knowledge, of course, the attitudes and their skills. I would add just my last contribution is that, of course, this is a challenge. It is more complex than it seems, and it will take, of course, years. Okay. However, I think that we could see it as an opportunity for all of us. Really great opportunity, not only to achieve the 4 goals of the quadruple aim, of course, but to achieve our own prestige and recognition. And in the level of institutions or health providers, even recognize prestige at an international level. So I will open the opportunity to start collaborating work with different institutions at international level, and the opportunity to carry out more research and even to create different handbooks or textbooks adapted to different types or kinds of professionals and entities. That's all.
Thank you very much, Aitor. That was so many fabulous ideas, and the work that you're doing is really incredible. And you even have examples of making it a very plain language and social, almost a social campaign to promote language access in your region. So I'm just going to turn it over to the rest of the panelists to see if there are any other things to add about mandating education, because we've heard about when it comes from the universities and the education systems and the professional orders, but just moving it more to be a requirement, even of the institutions hiring those individuals. I think that's going to lead us into call to action number 2, but just sort of a last call if there are any other comments for here.
I can comment, Grace. And first, thank you so much for setting this up, and big congratulations to Axel, Grace, and the whole Access Alliance team, because Access Alliance has been at the forefront of professionalization of interpreting since the very beginning. As far as I remember, 27 years, Access Alliance has been there. To add in regards to education of the healthcare providers, in the ideal world, part of the healthcare curriculum for all of them will have a diversity portion. It will have language access as part of the curriculum. We know that that's not the reality yet. And I love what Axel mentioned at the beginning of our panel in regards to we are all one. We are all responsible for that education. And this education needs to be consistent and on time. It has to become part of the culture of these organizations. That is not just a one time that we connected with one healthcare provider in a hospital and that healthcare provider is educated, then that person leaves and we go back to square one. So very important to make it consistent and to include all the stakeholders as part of that education.
Grace, if I may add something as well, just very quickly. Thank you, Aitor. Nice to see you again. It's been a couple of years. And thank you, Axel and Grace and Megan, for putting this on as well. Of course, I support, and echo what has been said so far. And sometimes it's interesting that how change comes about as well. So we work primarily in educating, training interpreters. And part of what we do with interpreters is also teach them self-advocacy skills and the assertiveness. So many interpreters will go into an assignment with healthcare staff that have not worked with interpreters, and they end up through their actions and their assertiveness and their professionalism educating, and from there comes this awareness. Of course, we need to mandate these things at the schools and the faculties, in our policy across the country, but at the same time, the practical experience of a healthcare worker, a healthcare professional, seeing what it means to work with a trained, interpreter, and how much, what confidentiality and professionalism and accuracy was demonstrated. So just that's sometimes you have to open multiple doors, to get to the core. Just wanted to add that.
And if there's time, I'd love to just piggyback on the points from my fellow panelists a bit. I'm really happy to be here today. When I worked at the Wellesley Institute, myself and colleagues put together a series of research studies on interpretation services in the Ontario context. And as part of that work, we did some qualitative interviews with healthcare workers at a couple different clinical sites that had implemented really strong interpretation services. And speaking to Lola's point, what we had found is that one of the biggest sort of markers of success was an organizational culture that valued the role of the interpreter as part of the care team, an organizational culture that recognized that interpretation is a part of the clinical care experience. It's not an add-on, it's not a nice to have, it is an integral part of patient and provider communication. And so I think, what Lola and Angela and Aitor have raised about the need for learning and adoption of these practices across the clinical team. It can't just be something that the interpreters are advocating for, or that clinicians are advocating for. Leadership in healthcare institutions also needs to buy into this, because it is a big cultural shift in those healthcare settings. And that's what we found when we looked at successful programs in Ontario.
I was just going to quickly jump in as well and just echo all the other panelists and say it's such an honor to be here and join this program. Thank you for organizing this. Access Alliance does amazing work, and we are sort of the benefactor of that as well. Our community really appreciates the support that we receive, and in terms of the call to action, one of the highlights that I found is, not only is it about language and understanding what's happening to a patient and the care part of it, but also there's a cultural context, and there's a lot of different pieces that come with language. And sometimes all of that is eliminated when we talk about care in our system, because of the lack of languages, because of the lack of understanding. So when you have a racialized woman or a Hindu or a Muslim woman in a setting, and she's not able to really have that communication, it eliminates a whole sort of world out there that the caregiver and the patient will never be able to grasp. And I think this call to action really highlights sort of the first stage for what we need to do in terms of getting to all of that and providing the care that we need.
Well, so thank you all. And I think Dolly just led us perfectly into call to action number 2 by saying that this one is the first step. And if we can go to call to action number 2, and I think this was really echoed in a lot of the comments that were already made, is how at the institutional level, we need to set some requirements and some policies. So I'll just read it out. So call to action number 2 is to integrate language access into the standards of practice and policies of Canadian healthcare institutions and performance measures of the health system. So I think with this one, we were handing it off to both Lola and Angela to kick us off, and then the others weigh in.
Yeah, absolutely, Grace. And it is of essence, it is extremely important that language access is included in those standards for healthcare systems, right? Now, in order for our healthcare systems to include this language access, the information and the standards have to come from somewhere. And that's where I want to go a little bit back to what it is that already exists. And back in 2007, we created the National Standards of Canada for interpreting. And this was a huge milestone for our industry. That happened to be the document that was used to create international standards on interpreting services, and also the one that is used by the Canadian Language Industry Association to certify interpreting service providers. So why is this important? All the standards have certain things in common. And one of them is setting up a structure that will define what the competencies and skills of professional interpreters are. And this is what makes the difference between a professional interpreter and a bilingual person, a volunteer at a hospital. We also identified that there are certain areas that is even more important to have professional interpreters and what these competencies are. And of course, healthcare services is at the very top of the list. So having these standards as part of our, education and part of the standards that are going to go into the access, portion of the healthcare standards, it is of essence. Our national standards also work together with the language interpreting training program. Also, Axel mentioned that before. We created that back in 2006, and with the new accreditation that we launched by the OCCI back in 2015. So we have been creating a structure over the last 25 years or so, professionalizing interpreting and setting that kind of foundation that the healthcare institutions can use in order to add to their own professional, and healthcare standards for healthcare institutions. So that will be the key piece that I think that they need, is to make sure that there is some congruency and they are aligned when introducing language access into their policies to make sure that they don't reinvent the wheel, but they come to the industry and see what is already there. What are the standards? What is the training? What is the existing accreditation? And even the next steps that we are working towards. Right now, we are doing advocacy, and we are working toward some kind of legislation. That is our next step. So definitely critical for healthcare institutions to include this and specific language access policies in their documentation and in their own policies, and instead of leaving it for the end of the process. So if we think of this as a process of quality assurance for patient care, we don't leave language access at the end, and only if we have the resources, we include that at the beginning. So Angela, I know that you have a little bit more directly related to healthcare.
Thank you, Lola. Yes, so just following on what you said, this congruency and alignment is very important. And often I see organizations thinking that there aren't these standards or an industry or profession that they can go to dialogue. And really it's about conversation. What is happening in the translation and interpreting standards sector? What's happening in the profession? How does it relate to the work that is done in this institution? In British Columbia, as an example, we have Provincial Language Service, and there is a representative here, and perhaps when the questions come up, we can ask her more information. There is a policy on language access. That policy was constructed through an informed process with stakeholders in the industry. And so it's a very good policy, but gaps still exist because what's missing? Oversight, enforcement, awareness, education. Why? The why has still not been satisfied, and it's not part of the standard. And I think the report said this needs to become a standard of care. This is not an add-on. This is a standard of care. The patient does not speak English or French. The patient's family does not check interpreter. It's a standard, it's a protocol that we integrate. So policies are great. It's a straight line, right? Groups of people come together, we create these standards that are very important, and they take a long time, right, Lola? They take years to develop, so they're not done slowly. With international colleagues, we take those, we integrate them into our national, regional realities, and then we enforce them and educate to them and share that they are there and why this will benefit not only the patient. This is not just about this, it's about the system as well, right? So I think policies, and I put it to the rest of the panel and to the attendees, how can we extend the impact of policies once they do happen, so they get life, they become real.
Can I just jump in there as well? I think Angela really, touched on something so fundamental, especially during this pandemic, that was so real. It was just so visible during the pandemic. I represent a very diverse riding in Scarborough. We have a lot of people from many different countries with many different languages. And when we talk about this call to action and what we need to do when we're really understanding how the care institutions have, in their best practices, whether language was even given that importance, whether, forget integration, just the fact that it wasn't really an important aspect of care. We saw that when COVID hit and the amount of information that was spread or the misinformation, and how do we sort of dissect that? When we had vaccine rollout, that was a huge problem. And one of the pieces that were addressed, or I think the city attempted to address, was why don't we try to reach people using different languages, using different brochures in different languages, hiring people from different communities as community liaison and who could speak other languages. And it was, too little, too late, because people had, COVID had spread and a lot of people were already struggling. And a lot of misinformation about vaccine, for example, had already spread. But it was still a necessary step And I think it really showed how important this step would be in terms of understanding and really integrating in policies. So when we talk about provincial policies or federal policies, are we really looking at how do we access healthcare? And I want to take a moment to just give a shout out to my friend Craig Carter Edwards, who joined the event today from the Language Access Coalition of Canada. And we've been working with the Language Access Coalition of Canada to really focus on languages. And during the pandemic, we understood the importance of it. And I think a lot of other policymakers understood the importance of that, which is normally not the case. So I know other panelists, and I'm sure Nishi has seen that as well in the work that she does.
Definitely. If I could maybe just jump in for a quick reflection. One of the things that this call to action makes me think of, I think, as Lola said, well, we don't need to reinvent the wheel. We have standards of care, and language access is a part of those already if we kind of expand our understanding of those standards. One of them that we focused on at the Wellesley Institute when we published this series of research on interpretation services was patients' right to provide informed consent. That is something that is the hallmark of patient autonomy and patient care. And when you sort of various statutes and regulatory frameworks around informed consent, it's very clear that if a patient can't communicate with their provider, can't ask questions, is relying on a family member or a friend or a hospital volunteer who isn't professionally trained, or maybe has opinions on their care and is inserting their opinions into that conversation, we can't possibly say that that patient is empowered to make thoughtful decisions about their care. So all this to say, I think as the other panelists have highlighted really well, language access is not sort of a new standard that needs to be sort of added on to the end of our existing standards. It's something that should be integrated throughout the standards of care that we already expect to receive in clinical settings.
Grace, can I just add something? I just want to circle back sometimes to political will. In Canada, we have access to justice as a charter right, that you can have access in any language, and we still are full of errors in our justice systems, from lack of interpreters to understanding to bilinguals, not interpreters, acting there. So sometimes a mandate is not enough. There needs to be education, and I really, really think that what's happening in our field is two things, in our profession, in our field, and I've been in this for 30 years, is two things. One, the what communication means in these environments is not fully understood, and what an interpreter does and who they are is not fully understood. Like Nishi said, issues of consent, confidentiality, it's disrespectful for a healthcare provider to assume that a non-English or non-French speaking patient does not deserve the same standard of privacy and confidentiality in care than an English or French. Like, that's just not, and I'm not speaking just about immigrant and refugee languages. I'm also speaking about Indigenous languages as well. We need to start looking at all of our constituencies in Canada and recognizing that this is, it's a right. It's a right to access. So there's, I think, lots of different pieces that need to be addressed as well.
If I could just jump in as well. I completely agree, Angela. And I think all of the comments are so on point. Who should be most interested in this conversation are insurers, healthcare insurers, High Rock, because the possibility of risk, and, in some instances, almost criminal risk, is huge. The impact of mistakes and errors, and there is research looking at that, is tremendous. And empowering providers within health serving organizations and other organizations too. I remember years and years ago, the Healthcare Interpretation Network, which was an advocacy and educational promotion network, we did an educational system, and we invited a psychiatrist. Actually, he worked in the emergency at one of our local hospitals and was a real advocate, and he said, it's ridiculous, in the emergency room, I can order a CT scan, which costs $5,000, but I cannot order an interpreter. You know what I mean? Like, I can't get an interpreter, which costs $50. And with that $50 intervention, I can get a lot more information potentially that will inform my decision making than that CT scan, which costs $5,000. But because providers are risk averse, and again, there's also research that speaks to this too, where you see providers ordering excessive amounts of tests in situations where they don't in fact have that language access because of their concerns about getting access to information that's going to help inform their decision making. So yeah, like standards of practice for providers and within healthcare institutions, yeah, it's huge. Anyhow, sorry, thank you. Great conversation, guys.
Hi, Tor, I see your hand up.
Yes, two aspects. First of all, well, I am a clinician and I agree with her absolutely. I mean, the most important source of information in order to establish a correct diagnosis is the patient herself or himself. I mean, not any other diagnosis probe. So, of course, it is cheaper than other diagnosis probes. It is more affordable to have a qualified interpreter on hand. Of course, I absolutely agree. Anyway, I don't think that all across the world, all managers or stakeholders do agree with us. And I think that many of them are not aware and are not committed with all this. Unfortunately, for example, in our country, they want to implement a semi-automatic or automatic translator, a machine, when I think that what I really need are people, qualified and professional interpreters. So please help us carry out the standards and embed this in our daily professional life, because unfortunately, and I'm really afraid, I'm really concerned of this, how they want to force us to use translators. We don't need translators, we need interpreters. So please, Angela and the others, please help us.
So just if anyone else wants to weigh in, before we move on to the next call to action, I just do want to say that we do have a lot of work to support us in the policies. There was a hospital guide that came out in 2012 that identified 5 high-risk clinical scenarios where if there is a language barrier, you are required, according to that hospital standard guide, you're required to use and work with a professional interpreter. And that was emergency care, informed consent, like Nishi mentioned, surgical care, medication reconciliation, and discharge. And so some providers will find a lot of strength in knowing that they have a list that they have to stick to. And sometimes policies really help not just to set an institutional's guidelines, but to empower people at the front line to carry out and to adhere to the best practices. So the more that we can give sort of checklists and decision matrices and specific lists for policies, the stronger frontline staff will feel in adhering and really promoting language access.
Grace, I just want to say one very quick thing speaking on that, because you just uploaded those 2 best practice checklists for working with interpreters in community and healthcare settings. It's not like one of these one-word checklists. There's a lot of content there, but you can get it at RioMix, just for people that might be interested in looking at that.
Right. So again, so riomix.ca, go in as guest and start typing best practices, and we've got 2 so far, and we'll continue loading more there. Okay, Megan.
I just wanted to mention there's a lot of good questions coming in the chat, and we're keeping track of those that we'll address near the end of the discussion. But just to be sure to change your 2 to everyone if you'd like everyone to see it. Otherwise, it just gets sent to host and panelist. So.
And I'm remiss to say that we're doing a time check. And for those of us who can stay on, we are definitely very far behind. We're only starting with call to action number 3 now. So hopefully you'll be able to stay on. And to our panelists, thank you so much for continuing to be here. So now, call to action number 3, and this will be an interesting one. So we're calling for a call to action to establish core government funding for healthcare institutions to ensure that interpreting services are included in standard budget lines. And so I believe that we have asked Dolly to lead us in the responses for this one.
Thank you, Grace. I was very happy that I got this one because it's very much the core of what I work in the provincial legislature, and focusing on how serious we are. Essentially, that's what it means. When we talk about funding, when we talk about investment, when we talk about any of the policies, especially the other discussions that we've had, even if you have great policies and motions have been passed in the legislature to understand the need and some of the policies put in place, if there are no funding, if there is no real investment made, then there really is no action. And that's what we see a lot in terms of some of the local policies or organizations that have been given a mandate. So when we talk about, the standard let me just give you an example with, we have 3 hospitals locally. And sometimes we are so tight in our budget with just the infrastructure, just focusing on care, just getting enough beds in our emergency rooms. I mean, language comes really, really far in that list of priorities. And that is heartbreaking. And the reason I want to focus on the human aspect of it is we are seeing the impact of the lack of funding, the lack of investment for languages, for interpretations in so many ways. The impact is so huge. We have a lot of complaints that we get in our office about the care because sometimes there is that huge gap. And it comes out when we see, once again, communities that are marginalized, people in families who need that support. If we're talking about a woman that's dealing with domestic violence and during this pandemic when they have been stuck at home and they need to be able to go and communicate that, and they're in that emergency room, there's a lot of different pieces that can be solved through this call to action. And right now we are missing that piece. So I think the seriousness needs to be there. The investment shows that seriousness, and to be able to have some of those bigger pieces in terms of national recognition, something that we've been working with here in the province and across. I've written to the Prime Minister asking for that national recognition for mother languages because it allows for us to really not just celebrate, but to be practical about it. I also noticed that in the comment sections, people talked about regional languages that are just spoken, different dialects. I come from a place where I have a dialect that's not really written. My parents, my family members speak in a dialect, which is very different from the usual books or the usual, language that's spoken in the across the country. What that means is even when you get an interpreter, because the healthcare worker or the institutions have only allocated, say, one, interpreter for that area or that region and that language, you may not be able to grasp the differences. And I think some of the guests on our event today really have honed into that issue as well, because some of those languages are kind of being lost because people are really trying to feel integrated within the community, but they're missing that part of themselves within as well. And what that means is people are not able to get that service. So going back to that, a woman that's facing domestic violence, if she comes from a place where she may not be able to find someone who she can communicate with the language that she wants, that mother tongue, then it becomes extremely difficult. And the establishing a core funding for languages shows that priority and that seriousness in the investment and making sure that we provide that service.
Can I add something, Grace? Sorry.
Definitely.
I think that if that core funding is not given along with, so policies might be enacted, but you need the resources, you need the human resources and the financial resources. What I've seen happen over the years is that there's a policy and now they start pitting certain departments against other departments, because now with the departments that need interpreters and ask for it, they have to find it somewhere else within their financial structures. It's not they're given extra money for the interpreters. So even internalized policies sometimes face that, that, well, we've done a policy, now what? It's up to you to get the money to support your service there, So that's another, that, money is very, very, very important. And I also want to say that when we talk about interpreters and we talk about language, we're talking about access through quality communication, not language, because Google Translate does language. We're talking about an informed, qualified human being that comes with an awareness and a contextualization to understand that my language comes from a culture that, is informing this interaction. So that's another thing too. I think that we need to kind of broaden that scope sometimes. And I'll stop now.
Yeah, and I would like to add to that we have definitely done some work in regards, and I believe Axel just posted on the chat as well, some research that measures the cost of the extra day at the hospital and so on. And I believe we have to do a better job on having data or measurements on the human cost, because that's something that tends to be sometimes ignored. And we look at numbers, but what happened with the side that no one sees, right? Like the invisible cost. And that is something that we can certainly improve in, identifying what really is that human cost that no one is seeing, or that person who never got to the hospital because simply felt, more vulnerable, and, that access was not there for them. And for us organizations, the other point that sometimes they don't see is the legal, action that can come through them, right? Like the potential, legal challenges that can come through the system. So that cost will be huge compared to what it would cost to pay for interpreting services. So there are many different avenues we can work in order to secure funding. But I believe that the one area that we have to focus a little bit more is that invisible human cost that we have not really done a great job documenting.
And Lola just reminded me one more thing that I forgot to mention, which was the cost that is put on the patient or the people who need that service. So when we talk about healthcare or legal services, or just the justice system, all of that, it becomes a huge barrier when we put it on the client, because a lot of the people who have these barriers are the one who are not able to pay the higher cost. And I agree with I think Angela mentioned, like, a machine is not. That's not the communication you need. So when Google Translate does it, you don't have any sort of cultural context. And that's why you have that cost, which we need to really take on and focus on how do we invest. And it needs to be government, it needs to be a bigger pool of funding.
So if I could just jump in, some things that echo the idea of mandating something before securing funding. A white paper was put out called The Perfect Storm, and it was in the US, and it was shortly after legislation required that language access be mandated across healthcare institutions. But then they established that you're pretty much creating a perfect storm here, because you've got this legislation, but no guarantee of funding. And so it's just problematic from the get-go. And so that The Perfect Storm is one of the papers referenced in the report. So I would encourage everyone to take a look at that when you're looking at what happens if you mandate something without securing funding for it. And then I'm just so pleased that we've brought up in this section the burden of disease and the impact on family and patients, because it's, we can quantify certain costs like unnecessary medical imaging, when instead, if there was good language support, we could get a better patient history. And I think this is going to really lead us into number 4 and talking about just how we really need to push for better research in this area, because there are a lot of things that we have not been able to figure out yet how to quantify and how to measure, as we're really looking at the impact on not just the system, but really looking at the individuals as well. So if I can just lead us into call to action number 4. So we're calling on research institutions to develop reliable ways to quantify the costs and benefits associated with investing in language access support within the healthcare system. So if I can hand it over to Nishi to take us into this area.
Sure. I have really enjoyed hearing from my fellow panelists, and I'm loving all the questions and comments that are coming in from the folks that are tuned in. I want to speak on this issue a little bit more from the perspective of an evaluator and a researcher who has done a little bit of work in this area. Access Alliance did an incredible job pulling together decades of research on this in this new report. But I will say that even with all of that work, there's a real dearth of evidence about the costs and benefits of interpretation services. So I think that this call to action is really spot on. There is a real need for more reliable data in this space. And so there's a couple kind of research and data areas that I think are clearly missing. I want to start by echoing something that Access Alliance and my colleagues at the Wellesley Institute have been saying for years now. We need better sociodemographic information collected from patients in Ontario. It's very hard to make the case for interpretation services when we can't even reliably talk about the number of patients who are hospitalized with X condition who speak X language. We need that baseline data so that we can start to understand what the impact of providing interpretation services versus not providing it is. And like I said, this is something that has really been amplified throughout the COVID pandemic, as Dahlia was saying. Understanding the health inequities that patients with limited English proficiency are facing, I think is this sort of foundational piece of information that we kind of don't collect consistently. I think that's an important starting point for sure. The second piece that I'd love to see more research on is, as our panelists who are involved in interpretation have spoken to, different types of interpretation and different. That's what our review at the Wellesley Institute found. That's what Access Alliance highlights in this report. And so I think it's also important to be able to break down and understand what the costs and benefits of, phone interpretation, when is it appropriate to use phone interpretation and what are the costs of that? When is it appropriate to use face-to-face interpretation and what are the costs and benefits of that? We've talked a little bit about this, sort of mobile, smartphone interpretation and maybe there is a situation where that's appropriate, but we don't know because we haven't done that research on sort of what the best practices are to implement it, or if we haven't been able to quantify kind of what the costs and benefits of those different modes are. So I think it's important to recognize that interpretation isn't a one size fits all type of intervention. There's going to be different types of interventions in different settings, and it's important that our research kind of breaks that out. And the third piece that I want to say, this is something that Lola raised. Cost is one of the 4 aims of the quadruple aim. It's not the be all and end all. And I think it's important to recognize that even though we expect that something like interpretation services would lead to cost savings in the long run, it could be a while before we're able to confidently say, okay, it did reduce readmission, it did increase appropriate utilization of care, et cetera. And so in that interim, while we're kind of tracking that data and building that case, we also need to be capturing metrics that tell us more about how these services influence the way that patients receive their care, influence the way that they build relationships with their providers, what the burden on caregivers and on loved ones is when these services are provided. So I think it is important for us to figure out kind of innovative ways to track that human cost, because I think that gives us a much bigger picture of the costs and benefits, right? When we say cost benefit analysis, we're all thinking dollar signs, but really there's a cost in terms of the burden of stress and the challenges that patients are facing in clinical settings that I think research institutions and healthcare institutions can be tracking, whether that's through patient surveys, provider surveys. These are the types of tools that we can be kind of rolling out at a larger scale so that we have a better picture of the kind of holistic costs and benefits, not just the dollars and cents. So I'll pause my comments there, and I'm eager to hear from my fellow panelists and from the audience about their thoughts here.
May I say something? I don't want to take up the space. Dolly, did you want to say something?
Sure. I can just quickly say when Nishi was talking about the the fact that we don't have the data, we don't have the information that we need to even actually go and prioritize funding and talk about how do we really do an analysis on this. And again, going back to the context of healthcare, or I don't know, this, like during the pandemic, I've had tenant issues where people are getting evicted on an online hearing where people have no idea what just happened to them. And in Ontario, I mean, just like right now happening. So it's as real as it gets, but the sad reality is we don't even have the data to go and argue and talk about what we need to do. And I 100% agree with Nishi that we have to focus on that. So I guess, and then I would love to hear from some of the folks who are here, who are on, in this field, working on it. How do we then go about making sure that some of these surveys are formulated in a way that we can actually gather that data? Because sometimes that's not accessible either. Some of the research, and I know governments spend a lot of money sometimes, and in a way by spend, I mean waste a lot of money on doing a lot of consultations and research, which I don't think really is not comprehensive enough, or does not grasp the actual demography of an area. Like, we still don't know how many of a so-and-so group of people live here, how many Italian versus Greek versus Bengali versus Pakistani, in my community, exact numbers, because some of the people, it's not accessible for them to fill out the StatsCan, etc. data that comes to them. How do we make it more accessible, and what are some of the steps that we can do to make sure that when it comes to a door, or maybe that's not the way to do it? And I guess it's sort of a comment and a question as well, because I'm kind of myself grappling with that still.
If I could just jump in, I mean, from my perspective as working in an organization that it's not just about interpretation. We're talking about access to determinants of health. I mean, this is about systemic discrimination and oppression. It's anti-racism work that we're doing, because the fact that our system, our mainstream dominant culture system, is allowing this situation. I mean, talk about research. This research isn't even funded. We funded this initiative, just like Nishi, I'm sure at the Wellesley, you self-funded these pieces of work. Nishi, you said something about collection of data. There was an initiative a few years ago, which was started as a pilot, but all health service providers are mandated to collect. It's 8 questions, ethno-racial data information, and it's through our funder, and it's in our funding contracts, but there's absolutely no consequences where, and hospitals have simply opted out. Community health centers are running around like, beavers collecting this data. Our data is not even pulled into health system data systems, and hospitals are just opting out, and funders are not. There are no consequences, even when it's part of our funding contracts. So, and that's where, systems change. We've seen lots of different pieces, but there's the bigger issue that is about systemic discrimination and a still lack of movement forward in some critical areas. And we know it's not just it's not just about newcomers. I mean, last week we had the National Day for Truth and Reconciliation, and we still have so much work to do in Canada to dismantle white supremacy. I mean, frankly, that's
systems of oppression.
Yeah, like it's still a big piece of work, and we're focusing in on this. So yeah, we need a lot of work.
It's interesting that you say that it's racist to not collect the data, and the argument that we encountered in the mid-90s when we were trying to get them to collect data at point of admission to the healthcare. Soon as the patient hits the healthcare system, add a couple of questions, and then we know. And the response was, that's racist, to start, disaggregating people based on language and where they're from. And that was the argument. I am happy to say that the RBC Human Rights Commission is moving the discussion forward, and I know that this year there were some big changes to that. But we just have to keep, it's a 30-year a fight that we've been, if not longer. So
Yeah.
and I want to also address what Nishi said about the different modes of delivery of interpreting services, and this is a big one. When I started in the field, we had volunteers and then we had trained interpreters, and this is late 80s. We had to, rather than say to people, well, which we did, but nonetheless, you can't use volunteers, we started creating a matrix about when you should use volunteers versus trained and why. And that is really what we need now, because there was a lot of resistance to remote interpreting from agencies for whatever reason, at least in BC. And then now it's like, wow, that saved us a lot of time and money. And now everything is remote. And it's like, okay, not everything can be remote. It doesn't always fit the situation. Interpreting in healthcare is not transactional. And that's the difference. And these are the arguments that happen on the international stage, as Lola can say, because some people say interpreting is interpreting. Yes, it is, but it's applied differently in different contexts, and we have to be sensitive to that. The interpreter is not invisible in healthcare, so it's not transactional. And the outcomes, should there be a bad interpreting a session or whatever, the outcome can be death, and we don't want that. So we need to start looking at these things, and also these new, I guess, whatever paradigms, that COVID has introduced as well.
And just a brief comment, I love the way, Nishi, you presented that in order, basically the ways to quantify that cost has to be holistic, because sometimes we also miss the exponential or the potential cost that it will happen a year from now. Mm-hmm. If today we don't see a patient that has an anxiety attack, and because that person didn't have access to language services, what happened a year from now is not going to be just an anxiety attack, and it's going to be way more expensive. So we also need to take in consideration, when we are looking at cost, is not only the present cost, but is that exponential cost, not only in terms of money, of course, but in terms of the experience of that patient, of basically having an aggravated situation 6 months, a year, 2 years from now. So I love that your holistic approach.
Right, and I would add there that one of the things we found in our research is that for certain healthcare utilization metrics, the outcomes are actually kind of a mixed bag for things like duration of appointment, for example. And so you might look at that data from a cost lens and say, well, it clearly costs more, the appointments take longer. But when you start to incorporate quality, okay, it took longer because the patient had a chance to ask questions. It took longer because the patient had the opportunity to build a trusting relationship with their healthcare provider that now they're going to feel comfortable continuing to come back. So, how do we, I would like us to find ways to kind of to measure that, to say, okay, yes, it took longer and today it costs more money, but as Lola's pointing out, what does that mean? What does that mean in the long term for healthcare quality, not just cost?
Oh, there's a good question here. Does anyone know if insurance providers will give discounts to providers, et cetera, who use professional interpretation services? That's something to advocate for. I see a little advocacy campaign right there. No, I don't think so. I don't think it's on the radar of insurers, unfortunately.
Oh, I think it is, and I think we can turn to the US to see, because where they have
such a litigious society.
Well, exactly. And Bruce Edelman's work is absolutely amazing in that field. And so anyone interested in that, Bruce Edelman has done a lot of work looking especially at the legislation and how insurance companies are potentially saving when they require health service providers to have interpreters and language access plans. So we can leverage that.
We need to really look at the Canadian context around that, because that has been something that's been discussed. And our malpractice legislation has a ceiling. It's a little bit different. I don't think anybody's going to get $19 million out of the Canadian health system like they did in the US. So we really need to work within our realities around things like that. Australia is probably a much better place for us to look at in terms of how do we integrate. They're not perfect, but how do we integrate these things?
Yeah, and looping back to our charter, where we have country of origin, but we don't name language as one of the restricted bases for discrimination. So we just need to give that a little bit of teeth So we name language there.
I saw a question that was for me, and it focused on something that I think Axel talked about in terms of data and how do we focus on really utilizing or maybe working together, that partnership. So instead of policymakers trying and going their own ways to figure out what to do, let's use organizations and people who are already working in the field, who have already been who have a huge understanding of systemic barriers and the systems of oppression that's already here and has existed for a very long time, and the data that they have. Why not invest in that? And I think that the question was excellent because he talked about how, maybe we just need political will. We need the political parties to understand. And the last comment that Craig made was Facebook has more information than we do. I mean, that just goes to show if we had that will, we should be able to get the data that we need to make some of these changes.
Absolutely. Wow. I see that we have 8 minutes left. And so if I can hand it over to Megan, maybe we have time for a couple of the questions that have been posted.
Okay, so in trying to, so some people have addressed some of the questions as they've been coming up. Something that I see that was repeated a few times and maybe some panelists could speak to is Indigenous languages and more remote communities, and even as a couple of people were bringing up the idea of those unwritten languages and just the challenges in interpretation around maybe speaking to one of those.
I think Grace might be able to speak to that a little bit, given the work we're trying to do in that area.
Well, for Indigenous languages, as agencies who have specialized for such a long time in settler and immigrant spoken languages, what we are seeking to do is to build partnerships with Indigenous language service providers, and so then build capacity to respond to the need by partnering with those agencies to access interpreters who are already working. And so that's the route that we're going, but there absolutely is a need, and COVID really shed light on just the reliance on sort of travel companions, patient navigators to be the language support. And so when COVID restrictions were in place and people weren't, there weren't travel companions allowed anymore, or there were restrictions, there were a lot of gaps in communication, and there wasn't the capacity to provide language support. So that is just what I would add there about just one route and one option for building capacity in that area. Are there any other initiatives that anyone can speak to specifically about Indigenous languages? Or even if the need that we're hearing about it. So Angela, out west.
Sorry, there is somebody here from the provincial health. I don't want to call out you if you want to say something, Steph. But we have a First Nations health authority in BC. We also have had for many years First Nations large department within the Provincial Health Services Authority. What's happening specifically, I'm not very clear, but there is these entities, these bodies are a presence, right? And I think that, I don't know how many of you have read Sarah Bowen's, seminal report around access to healthcare, and her identification of the 4 constituencies. It was just like, it was a perfect, wonderful, statement, the way that she looked at things at that time, saying that we're not just talking about access via language when we're looking at the different constituencies. So, in terms of First Nations language, Indigenous languages, we need to be respectful of so much more than the language, and there's so much as well within that about language, like maintaining the language as well. That's another issue, right? It's not just about using, but how do we keep this language growing and living? So there's many issues. As I said, we do have the First Nations Health Authority here in British Columbia, which is the province-wide health authority. But
we have a wonderful opportunity in Canada right now with the appointment of a Governor General who speaks an Indigenous language, and in fact, right from her first public engagement has spoken her language, and in fact has said, and honestly, I'm just blanking right now on her name. I wish I could say her name out of respect, if anybody could think of it, but pardon me?
Mary Simon.
Right, and it's a huge opportunity, and she in fact has said, we're more than a bilingual country. We have, many original languages that we have to. So, I mean, what might be the opportunity? And, in the work that we did many years ago in the Health Interpretation Network, we always talked about we need champions. We need more than us. We need these high-profile champions to start raising the awareness. And maybe there's some opportunity there. I know a senator. Maybe the senator can help us get to the Governor General. And anyhow. Just a comment. Our new Governor General.
Just a comment. Oh, excuse me. Just a comment. I speak an Aboriginal or Indigenous language. My own language is Basque, and it is not a mere question of communication. We just want to keep it alive, to survive. We are a few thousand, and our language was out of law beyond the pale. 40 years ago, until 40 years ago, it was forbidden to speak in public our language. So I understand the Indigenous and the First Nations is very, very important. And is it not a question only of communication? It is our identity, is our being. We call ourselves, for example, Uskaldanak, those who speak the language. I'm not identified by my origin or where I was born, but for my language. And it's really, really important for us to survive, just to survive.
Yeah, thank you.
And just to add, in terms of the initiatives, I'm not sure if we have anyone from the federal government on the call, and I am aware that the Translation Bureau of Canada has been doing extensive amount of work to increase the services and the awareness and, basically work with the different Indigenous languages. So they have been focusing on that over the last few years, and which is a positive thing.
If I can add just a couple of other points from, or maybe it's just one other point from the questions that have come up, and we'll be sure to address the other questions in a follow-up. But it came up a little bit about culturally safe, culturally sensitive, trauma-informed, gender affirming, and like those kinds of words were coming up in a number of questions. I'm kind of bringing them together in the sense that people have already been talking about that it's not just about understanding, it's about it's not just about comprehension, it's a deeper understanding that you're all sort of bringing into the conversation, which I think is very interesting. And I think a totally separate kind of approach to advocacy in this area. If anybody wants to speak to that or any other sort of last comments before we wrap up.
Thank you very much for organizing this. This was a fantastic discussion. And honestly, I feel like we could have a lot more in-depth conversation about the questions that were asked as well. So thank you for organizing this.
Yeah, I want to thank you as well. And I want to ask, in order to just keep the momentum, you're going to be sharing the recording, I understand, but is there some place as well where we can connect across the country on these issues and continue the discussion?
So we're going to be sending out a feedback survey, and in that we will be adding a question, especially because we saw all the connections that are happening in the chat today, asking if you would like to sort of be part of, at least we'll begin with an email distribution group to continue these discussions, and then from there we'll see what options are, because I really think there is there's a call for a platform for us to continue exchanging.
Agree. Thank you, and Excel and Megan for this.
Yeah, thank you, Megan, Excel, Grace, and Access Alliance. It was
No, and
wonderful.
thank you to the panelists. It was great to have your presentations, and also the discussion among you was fantastic. So I super appreciate it. And we'll keep all of the chat notes too.
Yeah. And this is a great reminder for Unity that we have discussed for so many years, and how we all need to work together to make this, a reality. All this call to action would not happen just by one.
No.
Right? So we really need to keep working together.
Yeah, totally.
Together is stronger.
Yes. Thank you, everyone, for taking part and for all your time, and to everyone who attended. So a big thank you, and we will be continuing.
Thank
you very much. See you.
Bye. Nice seeing you again,
Bye.
Aitor.
Bye.